Thank you for having me today. My voice is usually pretty loud enough, so even people back there should be able to hear me. I'm going to spend about 15 minutes talking about dry eye, which is probably the most common condition that we're seeing in ophthalmology nowadays. And we'll talk a little bit why that is. I spent the last 23 years in Pennsylvania in a large private practice, moved down here in July, and I picked the best year to move with the weather they had up north. So I'm happy I'm here. So basically, the tear film, you know, most of us think of it as, oh, just some fluid on the surface of the eye, but it's actually very important. It's important enough that it focuses about 10% of the image that you see, okay? Everybody thinks about the cornea and the lens, but the tear film is pretty important because of that. And if you have an inadequate tear film, it's irregular, you have a dry eye, you have other problems with inflammation that makes that tear film irregular, your vision can be blurry and it can be fluctuating. So the tear drainage system, most people will just think about the lacrimal system, which is a lacrimal gland coming up here, but most of your tears are going to come from the lids and the conjunctiva, and I'll show you some pictures that shows that. So there's 3 layers to the tear film. The outer oily layer produced by the meibomian glands, and those are the 40 glands in the lower lid, the 30 in the upper lid, and they're probably the most important because that lipid helps retard evaporation. About 86% of folks that have dry eye have evaporative dry eye, and we know that from the National Institutes of Health Dry Eye Workshop. The last one was 2007, and this has become the sort of the mainstay of treatment nowadays, recognizing meibomian gland dysfunction and treating it appropriately so that your dry eye can be treated. The days of just giving you tears and putting plugs in, it's changed quite a bit. It's an inflammatory condition, we know that now. The middle layer is the aqueous layer. That's the layer that normally comes from your lacrimal gland that also will turn on when you're cutting an onion or emotional tearing. But it's not a huge layer. The innermost layer, the mucin layer, comes from the goblet cells in the conjunctiva, and the conjunctiva is the thin film that covers the white part of the eye. So there are 3 components to the tear film, but the most important for most of us for dry eye and dealing with it is the outer one and the middle one. So tears are produced by 2 different methods, as we talked about. You have the slow, steady basal rate that comes from your lacrimal apparatus, your meibomian glands, and your goblet cells. And then the reflex rate. Something gets in the eye, something's irritating the eye. The cornea sends a signal to the brain. Hey, it hurts down here. Let's turn on the faucet. So then your lacrimal gland turns on. And that is what a lot of us think that, well, how can I have dry eye? I'm tearing all the time. Well, that's one of the more common things that we see in dry eye is reflex tearing. So the dry eye is either a lack of production of tears, which is a very small percentage of folks, and the most common is basically the tear film evaporates too quickly. It doesn't stay on that tear surface, so your eye dries out that way. The nerves at the end of the cornea get irritated, and then you get the excessive tearing. That's why many of you, if you have dry eye, you know if you're in a long car ride and you have the vents blowing at you, or you have the windows open and air is coming in, wind, air blowing at you causes that dry eye to be a little bit worse, and it causes you to tear, and that's why. I'm going to, just because our time's limited, I want to get through a few major things. So symptoms: stinging, burning of the eyes, scratchiness, stringy mucus called filaments that can form, excessive eye irritation from smoke or wind, anything in the environment can do that, excessive tearing that we talked about, difficulty wearing contacts or putting anything on the eye, or you're using eyeliner or makeup and the eyes get a lot more irritated. And I'm not talking about, when I'm talking about dry eye, I'm not talking about the itchy sensation many of us get this time of year with allergies, with the pollen and all that. I'm talking about a gritty, sandy feeling. And so itching, if you just want to rub the eyes, that's really a hallmark of allergy, okay? Whereas dry eye itself, now that can be made much worse in allergy season, but dry eye itself is more for that gritty, sandy sensation. Biggest thing is fluctuating vision. So in other words, you sit down to read a book and you start to read and you're 20 minutes later, boy, my vision's just all over the place. I have to blink a bunch of times. Or if you haven't figured it out, you go and put a teardrop in, and then for the next half hour, you're good again. When we read, when we're looking at our computer, smartphones, we tend not to blink as much. And so If you think of as your ocular surface and your blinking mechanism almost like a windshield wiper that's moving that tear film across the cornea and trying to make it nice and even. If your tear film is thick or thin, it really doesn't matter. Your vision is going to stay pretty stable. If your tear film is irregular, that's when it starts to cause fluctuating vision. We talked about tear production can be decreased. The biggest thing, though, is really evaporation. Women, 9 times more frequent than men to develop dry eye as hormone levels change. So often in your mid-40s and up, you'll start to, and if you remember, you think, well, that's when I did start to have some problems with dry eye. There are many other issues that can cause dry eye. There are autoimmune conditions. The lupus is the rheumatoid arthritis, Sjogren's syndrome, which I'm sure many of you have heard of, that it causes dry mouth, dry eye, and it causes rheumatoid arthritis-like symptoms in the small joints of usually your hands and your toes. So medications are a common cause for dry eye. Many medications. And so I'm not gonna, this is not an all-inclusive list either. But practically any medication, that's something to think about. But usually you need that medication for some other reason. So that's where we try to support you with that by using artificial tears or anti-inflammatories locally to the eye and to the lids. Now, the lid margins that I talked about, blepharitis, that's when you get the little sort of collarettes that form on the lashes. They're dry tears. And you may have been told in the past to use Johnson's baby shampoo or some eye washes to wash the lids. Baby shampoo with Q-tip, with dilute, going back and forth 10 times is a good way to get those off. But the best thing to do is a warm compress beforehand. And what this picture is showing is basically the meibomian gland orifices here. And what we like to see is clear fluid like that. That you can see is a little more turbid. So when you have meibomian gland dysfunction or MGD, think of it instead of like a bubbler where water is coming out, that fluid's coming out, it's coming out almost like toothpaste. So it's thicker. And I'm not exaggerating, that's what happens. And what happens is people that have had bad meibomian gland disease, somebody that has rosacea, and that's the blood vessels you get on the nose and the face, and they can get it on the eyes, those glands actually atrophy. And so what happens is their eyelids start to notch in different areas. So often our treatment is try to get involved before you get to that point, because if those glands totally atrophy, I can't get those to function again. If they're blocked and the secretions are turbid, we can do something before that happens. Rare diseases, vitamin A deficiency we don't see too often in the United States, Stevens-Johnson, ocular cicatricial pemphigoid, all things that cause scarring of the conjunctiva, either induced by medications or with a systemic condition. And again, those are things that can cause severe dry eye. So, dry eye, there's 2 standard tests. One is called the Schirmer's test, which has been around for years. That's a filter paper that's put in the eye. Many of you may have had that done. It's not as commonly used nowadays, but it's still an excellent test. And then the more often we'll use what's called tear breakup time, where that fluorescein dye is put in the eye, the yellow-orange dye that your ophthalmologist or optometrist will put in the eye to check your pressure. We're also looking at the tear film, and it gives us a good picture of how the cells are staining. And so tear breakup time is what we all look at, and we're looking to see, is it over 10, which is normal, or is it less than 10? And everybody with a dry eye has a decreased tear breakup time. Standard nowadays is tear osmolarity, and it's been that way for the last couple of years. When I was a fellow at Hopkins back in '92, we used to take pipettes, collect this, send it to the lab. It'd take 4 to 6 weeks to get the result back, and it really didn't help. Now it's a 2-minute test in the office, and it looks like the old thermometers that you could check the temperature in the ear. There's a disposable nano chip that goes at the end. It collects 50 nanoliters of tear, and within 30 seconds of going back in the base, it gives us a measurement. And it's just like your blood osmolarity. The normal is 280 to 295. If it's elevated, nothing else does that but dry eye. And so you can have other inflammatory process in the eye, but it won't elevate this. So it's one of the most specific and sensitive tests for dry eye. So how do we treat dry eye? Well, you all know about tears. You know, and artificial tears are great, and there's many different types. Somebody that has a mild dry eye, it doesn't matter which teardrop they use. They just need to keep it lubricated as long as it is a tear and not just a get the red out drop. But if it has an artificial tear in it, it's good. And people that use tears more than 6 times a day, we usually recommend a preservative-free tear. The reason being is once you're starting to put that drop in more than 6 times a day, the preservative in it can actually make the dry eye a little bit worse. So that's important, and that's often something that hasn't been explained to individuals when they're using tears. And so then we get into the next step. So of course you start with tears. Cyclosporin, which is Restasis. I'm sure you've all seen Restasis advertised on TV. As a cornea specialist, we call it liquid gold because it's so expensive, but it has a patent for another 14 years. They just the Allergan won a case. We thought it was going to become generic, but they have a patent until 2028, I think it is, now. But basically, Restasis has revolutionized how we treat dry eye. It's the only FDA-approved anti-inflammatory for dry eye, and it works by modulating T-cell inflammation. But what we know is after it was approved, studies have shown that it actually cuts down the inflammation in the lids for meibomian gland dysfunction, and it actually, for folks that have autoimmune conditions, it really works very well. It works for most dry eye patients. Problem is it takes about 3 months to kick in, and so that's what's frustrating for most folks. Most people that will go on Restasis will stay on it. In addition to their tears, they'll stay on Restasis for at least a year to see how it's working. Some people, doesn't matter if we think we could get them off it, they want to stay on it forever because their eyes feel that much better. We have other folks who will get off for a year and then they'll be back on in a couple of years with it. So it's a good medication, but remember the key with dry eye is nobody can cure it, we can treat it. And the whole goal with the treatment is to get it so that you can live life normally. People that have, and I'm sure you all know people that have severe dry eye, it's miserable for them and they can't function, they can't drive, there's certain things. And so the key is to get them back to where they can live a normal life. Steroid drops we all often use to try to quiet down that inflammation. Topical antibiotic drops we use also to decrease the bacterial colony count that lives on the lid margins that we all have. Colony count goes up, that's normal staph that lives there, produces toxin, thus more inflammation. So it's a vicious cycle. Oral medications like doxycycline work great, and it's not because you have an infection, it's because it gets into the lids and it actually helps secrete that lipid I talked about, that outer layer, to retard evaporation. The fish oils, the omega-3s, the omega-6s are all good. And these are all things you should ask your ophthalmologist or optometrist about. Conserving the tears, basically punctal plugs. They used to be used quite a bit. Years ago, everybody would get tears and they would get plugs. Well, we now know, this is before we knew dry eye was an inflammatory condition. So nowadays, plugs are probably 4th or 5th on the list because you want to get that inflammation settled down. Because think of the plug as putting a bathtub drain in. If you have all those inflammatory cells and now you're welling up that tear film, it's not really treating the underlying problem. It could actually make the inflammation on the corneal surface a little bit worse. Great thing for a lot of people is just having a humidifier in the room or a pan of water in the bedroom at night. Anything that you can get some moisture into the air, that helps quite a bit. The latest treatment that was approved in 2012 is LipiFlow, and it's a way to treat meibomian gland dysfunction in the office versus using the warm compresses all the time. There are different ways to use warm compresses, whether it's the heat mask that you can buy in any of the drugstores, you put in a microwave and heat it. You want to be careful when you do that because every once in a while I'll see somebody that your hands have a lot thicker skin than your eyelids. They'll pull it out and they put it right on and they burn the lid. So you have to be careful with that. Moist heat with a face cloth, wet moist heat is a little safer thing. The best way to use those compresses is basically put it in the water as warm as you can tolerate, put it up on the lids. After 30 seconds it starts to cool down, put it back in the water, wring it out, do the same thing. Do that for about 5 minutes or 10 applications. That works very well and it's pretty safe to do. LipiFlow came about as a 12-minute treatment for a way that you could treat this condition and not have to do the warm compresses and basically get 9 months to 15 months of significant relief for the meibomian gland dysfunction. And what it looks like is this. There's one machine called LipiView that actually can show us all the individual glands, and it's a great educational tool for all of you to see if you have that problem. And then this is what LipiFlow involves. Basically just sitting in the exam chair, putting back. That's an applicator that cups over the eye, doesn't actually touch the eye, wraps over the upper lid and the lower lid. It's actually, a lot of people tell me when they have it, they say, wow, this 12 minutes was like being at the spa. It feels that nice because it's warm heat. It takes your normal temperature is 98.6. It elevates that applicator, elevates on the lids the heat to 108.5 degrees, and then does 2 6-minute cycles of pressing on the lids. And it does different types of things, but the whole goal is to milk the secretions out of those lids, those turbid secretions I showed you. It warms them up and then tries to express them. That day you feel great. The next day, if we did it, you might say, Dr. Leahey didn't do anything, it feels the same. And then all of a sudden, 3 to 5 weeks later, you feel a big difference as the lipid starts to flow out like it should and it's not evaporating. This is just a close-up view of what it is. Now normally you'll have a piece of tape going up here and a piece of tape over there to make it very tight, but for picture reasons we have it that way so you can see it. So basically dry eye is a condition that's come a long way as how we can treat it, but again, we can't cure it. And it's a frustrating condition. Often as a cornea specialist, by the time I'm seeing somebody that has bad dry eye, they've seen 6 to 8 different ophthalmologists or optometrists, and it always amazes me, no one's ever told them this is not something we can cure, but we can treat. And that's one of the biggest things, is understanding the disease process, any condition you have, and knowing what we can and what you can't do with it. So that's, I know I went through that fast, but I was informed 15 minutes and then the rest for questions. So, and normally I'll do this in about half an hour, so hopefully I didn't go too fast. But I'll take any questions. Yes?